Thank you. So good morning, everybody. Happy Tuesday. Welcome, welcome. If you're a Memphian, I know we're finally through surviving the snow apocalypse, and I hope everybody survived just as well as I did and stayed warm. We are definitely Memphis as we have now way higher temperatures than what we had last week. So with that being said, I want to go ahead and introduce today's End HIV 901 Technical Assistance Training. Our consultants, Ms. Judith Montenegro and Jesse Claudio. Judith Montenegro is the program director of Latino Commission on AIDS, also known as Latinos in the South. And we also have Jesse Claudio. He's the community engagement manager. Additionally, as well with Latino Commission on AIDS, Latinos in the South. As we all know, Jesse, he has been a part of our community for many, many years, and we all love and adore the work, and not adore, but completely support the work that Latino Commission on AIDS does. And so when they agreed to do this training, I got very, very excited. So with that being said, on today's training, we'll be incorporating language justice and ending the epidemic efforts. And I'm going to go ahead and turn it over to my colleagues with Latinos Commission on AIDS. Thank you. And a quick FYI, so if you are not presenting, please be sure to have your cameras off and your speakers muted when opportunity does come available for questions. We will definitely monitor those, and I will be on the monitoring the chat box in addition to our presenters presenting. Thank you.
Thanks so much, Elizabeth, and good morning, everyone. As Elizabeth mentioned, my name is Judith Montenegro, and I'm joined by my amazing colleague, Jesse Claudio. Jesse, do you wanna? I mean, I think you know a lot of the Memphis folks, but I don't know if you want to give a quick hello.
Yeah, no, good morning, everyone. Good morning, y'all. I am super, super excited to be here. As you guys know, have been doing this work for quite some time, and I'm excited to kind of just share my new role, the new organization that I'm with, and kind of hopefully share some light on a different way of looking at the HIV care continuum through a language justice lens. And more than anything, I'm also super excited for y'all to meet my incredible supervisor, who's also our program director, Judith. And so, yeah, I'm just super, super excited to be here with y'all. And after this presentation, if any of you guys want to kind of take a deeper dive or conversation, you guys have my contact, and I'll be more than happy to follow up with you guys. Without further ado, back to you, Judith.
Thank you, Jesse. So I wanted to start off by sharing a little bit about the Latino Commission on AIDS. We were founded in 1990 to really work on some advocacy efforts, promote HIV education, develop model prevention programs, and do capacity building for community-based organizations, AIDS service organizations, health departments, faith-based institutions to address HIV and chronic health conditions in Latinx and Hispanic communities. We really work nationally to address these challenges and what the impact of HIV, viral hepatitis, and STIs have on our communities. And so I'd like to share about our program, which is in the South. I'm based in North Carolina. But our Latinos in the South program, which is part of the commission, um, we were founded in 2007, and part of our work was really to address the increased Latinx population here in the Southeast. We saw that the epidemic was centered here. The South is the epicenter of the HIV epidemic. However, with the influx of new migrants, the South became a new destination for a lot of immigrants in states where historically we hadn't seen large Latinx communities. North Carolina, Georgia, and Louisiana saw some of the biggest increases. Later on in 2019, we added Texas and Florida to our states. So we work out of 9 states now. And we also provide capacity building, community organizing, leadership development, networking initiatives. And so that's part of the work that we do. Jesse, of course, is our community engagement manager. So he's been working with community members and organizations across the Southeast. So we're really excited to be able to have this conversation and share about language justice. And Jesse has asked y'all in the chat if you all could do just like a brief intro with your name and pronouns and your organization. There's also a way on WebEx to add your pronouns. I'm not quite sure how to do it. This is my first time presenting on the platform. I've participated, but so I think there may be something that can happen to add pronouns, but please do so.
And there is real quickly, briefly, for those of you guys who've never added, or changed your name, if you click on your screen, there should appear three little dots, and then at the very bottom, it says Edit Display Name, and when you click on it, it gives you the chance to edit the name that's being displayed. And if y'all can just add your pronouns, that would be incredible. This will be an interactive presentation. So when engaging with you guys, we want to make sure that we're being respectful and mindful. So that would help us. Thanks, y'all.
So I'll give folks a few, like another minute to add their names and pronouns and their organization, just so I have a better idea of who's joining us today. So welcome, Ray. Thank you, Elizabeth. Welcome, Krista and Dominic and Kate. Thank you for joining us. Welcome, Sierra. Thanks for joining us. All right, so folks keep adding your names, but we're gonna move on to our icebreaker. And Jesse, if you can give me a little bit of support, let's see, with the Mentimeter. So if you haven't used a Mentimeter before, there's two ways you can access our poll, and that is through the link in the chat or through our icebreaker, or I'm sorry, through the QR code. So I'll give folks a second to access. Welcome, Robin.
And I already added the link in the chat for y'all.
Mm-hmm. So I'm going to give folks a quick second to access that. Is anyone having any issues? And honestly, like I want you all to know that I want to encourage you all to be trolls and to be internet trolls, which means I want you all to participate in the chat function if you're not comfortable, sharing out loud. But our first question is, what is the first word that comes to mind when you hear the term language justice? Oh. So we have beach, sunrise, tamales, bear and taco, equity. Okay. Maybe somebody was testing to see if it was going through. No stigma. Yep. I do love tacos though. There is some justice in tacos. Oh, welcome, Will. Can you drop the link again, Jesse, so folks can, in case they haven't had a chance? I'm going to give folks a few more minutes or maybe 1 minute, 1 or 2 minutes. Communication, patience, humility, access, no stigma, respect. That's good. We're seeing some, as our word cloud, as we get more terms and people are using similar terms, they get bigger. Mhm. Well, most of these are right? When we talk about language justice, we're not necessarily talking about beaches or sunrise, but we are talking about equity and humility and stigma and respect and empathy, right? So we'll come back to our Mentimeter. So if you don't want to close it out of your window, you don't have to. So part of our goals of this workshop is to really encourage community members and stakeholders to know that the concept and practice of language justice goes beyond accessibility. So many of you may be familiar with accessibility as providing interpretation, having a, a documents translated. And a lot of times that those interactions are one-sided, right? Like usually it is a provider providing access to a community, but it's not necessarily a two-way street, right? Like the communication isn't always throughout the entire interaction. It's really just one way. And so part of what language justice does is that we talk beyond accessibility. It is looking beyond just people having access to these tools, but what do these tools look like? What kind of investments are we making? What is our focus area? And it's also to recognize that language in itself can be a form of healing, and it can innovate our organizational priorities and lead to stronger health outcomes for our communities and really help us end the HIV epidemic in the South and beyond. And so when we think about language justice, I want you all to consider these 5 things. That language justice is about gender neutral language, right? It is about language access. It includes people first language, which we saw as part of our word cloud. It includes non-stigmatizing language. We saw that too. And then we also saw that some affirming language, right? Being empathetic. So we'll go through some examples of what those look like. But I want you all to think of those 5 ways. And so as we go through this exercise and through this workshop, understanding that, when we use gender neutral language, when we use people first language, when we invest in non-stigmatizing language, when we train our staff to be more affirming, and how that reflects in the language that we use, and then the language access piece within language access plans, right? Making sure we're able to communicate with folks who English may not be their first language, or may have or who may use ASL, right? All of these things are incorporated into language justice. So it's not just about working with communities who are monolingual Spanish speakers, but it's looking at all the intersections that our communities face. And please feel free to add any comments or questions in the chat. So I want to share a little bit about what the South looks like from our perspective and for how we approach our work. We understand that the South is one of the most diverse regions in the US, and that it is also the epicenter of the HIV epidemic and has the most EHE jurisdictions, right? And because it continues to be one of the most diverse regions in the nation, we also understand that the Latinx community is set to reach 30% by 2030. However, the supply of Latinx physicians is declining, especially in the South. Folks are moving away from the South. We've seen a lot of nurses, a lot of folks leave because of some of the politics that have all of the things that have happened. I think there was an article from Tennessee from a physician who said that they were leaving because they could no longer provide gender affirming care, and that they would be risking prosecution for their work. And so, some of the policies, bills that are being introduced have a direct impact not only on the patients but also on the providers, right? And their responsibility to care. And so we are seeing folks leave their practices and hospitals. Um, we also see that more than 1/10 of the US population ages 5 and over qualify as having limited English proficiency. And yet, we also see that a lot of organizations rarely budget for interpretation and translation services as regular line items. And today's workshop and training is going to focus mostly on Latinx communities and addressing some of the pieces around language. But I also want to consider LGBTQ communities. I want us to think about people living with HIV and using people's first language, right? Like, there's more intersections that we can be introducing and participating in as we go through this. So some data from Shelby County, and I also included a comparison to the state, just so we could see like how Shelby County compares to Tennessee overall. So we can see that in 2021, there were 6,550 people living with HIV in Shelby County. 3.8% of newly diagnosed individuals are Latinos in Shelby, and they make up 5.6% of the population. So that's a difference from the state, right, where we have 10.5% of newly diagnosed individuals are Latinos, but they are only 6.4% of the state population. So there's a bigger disparity at the state level than in Shelby County. But we're going to do a little bit of a deeper dive so we can see some of these figures and how they spread out. And as we sort of think about this, and we think about the role that language plays in looking at these figures, I do want to share that language is a real integral part of healthcare. First, it's a right? Like, it's folks who are receiving federal funding have an obligation and a duty to ensure that their patients understand in their language. But we also know that researchers have found that language barriers between patients and healthcare providers can result in longer hospital stays, more medical errors, and lower patient satisfaction. We also know that, in research, patients who didn't speak the same language as their physicians were less likely to receive lifestyle counseling and diet, exercise, and smoke cessation. And in turn, even having with a clinic interpreter, and it allowed for health education to take place and partially overcome that barrier. So even when you had the interpreter there to sort of help, the quality of the healthcare is the ratings were still not that much better, because the quality of interpersonal care, of being able to communicate in your own language, having an interpreter does not substitute for that, for having a shared language. There's a level of intimacy that we have with our physicians, and that needs to be established in that relationship, right? And being able to communicate, and being able to share, right, what some of our afflictions, our concerns, our symptoms, in a way where you feel comfortable. And when you have a third party there, it can sometimes be difficult, or folks can feel shame in having to communicate that directly to the interpreter. So I just wanted to share that. But in 2019, and this is actually when we met Jesse, Jesse when we were doing our assessment around LGBTQ Latinx Southerners in healthcare. And this really speaks to the piece around being able to be affirming to folks as part of their healthcare, where we learned that 72% of respondents with at least one medical provider was aware of their LGBTQ identity. But about 27% of that sample had a provider that reacted poorly upon learning of their Latinx sexual and gender identity during their lifetime. And that, we also asked them, do your providers understand or are knowledgeable about what it is to be Latinx and LGBTQ and the health, the unique health approaches that need to be taken. And they only said that their providers were only somewhat knowledgeable. They also stated that their comfort level in seeking medical care within their community was only about average. So we're not seeing like communities, LGBTQ Latinx communities in the South really like rushing to their providers to see them or having really great experiences. And I think that's something we can reflect on. They also stated that living in the South was the biggest burden on accessing healthcare, so geography plays a major role. But also, when we think about the South, it's also the political space of the South and what that means. It is not just the geographical, right? It is the economic, the historical, right? All of these other factors that embody the South. And when we asked what were their top health conditions that they were the most concerned about, we saw mental health at the highest, then HIV and STIs, and then suicide, right? Depression and
I
so
also
that's
want
what. Go ahead.
sorry, Judith. I also wanted to add, you guys, with this slide and the previous slide, that these are really important, huge factors that play a role on how the HIV care continuum looks, not just within our county, but also within our state. All of these factors that Judith mentioned truly are indicators on some of these figures, and also some of these barriers that we tend to see, not just within the queer Latinx community, but within our community as a whole, right? Just beyond that demographic. But yes, back to you, Judith. Thank you.
Thanks, Jesse. So then we remix the continuum of care a little bit. I can't remember who had done the bar before the bars initially, but we added some additional pieces. So language really will manifest itself in terms of service delivery, access, and treatment. But we also added language here because language plays a really integral role in how a person experiences healthcare. So whether it's their first encounter with intake forms or at the reception, signs in the parking lot, or in conversation with their provider to share about their needs, um, it continues all the way through into how people understand their diagnosis and treatment plans, right? And I think we're going to look at some of the figures where I think we can strategize together on how to address some of these things. But really, we understand that identities also come that are stigmatized, right? So, and they impact adherence. Like if you're an immigrant, someone with limited English proficiency, maybe you're uninsured, there are strategies we can use to sort of address some of the language that is affecting adherence and stigma. And that includes, right, using chosen names and pronouns or gender neutral language. We know that when anti-LGBTQ legislation is introduced, when we continue to systemically look at a community, and challenge and attack, that rates of HIV infections are going to rise, right? Because people are no longer going to feel comfortable sharing with their providers their needs, their behaviors, what they're doing, and so that does not create healthy communities. We also want people who, regardless of their legal status, um, we know that there's a drop in healthcare access when anti-immigrant sentiment and legislation becomes rampant, right? When we talk about public charge, that then even if there aren't any changes to public charge, even if um, there aren't the anti-immigrant legislation isn't passed, we still see the behaviors of our communities become fearful of sharing their information with health departments. They're not driving to their doctor's appointments. Maybe they'll take their kids, but not themselves because they're not going to risk more. And that happens not just with folks who are undocumented, but people with mixed status families who don't want to attract attention. So these are things that we need to keep in mind. The medical forms that we use, are they available in different languages? And we'll do a little bit of reflection here. And is there a box for non-binary or trans individuals as folks are coming in? This all sends messages that the provider understands and sees the patient as a person, as a human, and is going to treat them with dignity, right? um, being able to access and navigate medical spaces. There are exercises that staff can do in terms of community mapping. We used to do a training pre-COVID where we would go into providers or organizations and alongside with staff and sort of do a mapping about what it looks like to visit that space. Um, is it easy to navigate the space? Do I need to ask for assistance? Do I have to interact with people when I'm unsure and I might not trust y'all, right? So we also found that people who, I was talking to someone when we did our assessment back in another assessment in 2015, where a man came into the emergency room in South Carolina, was given an HIV diagnosis. It was a he came in to the emergency room because he was very sick, and so it was a late diagnosis. They treated him, provided him with medications, and the patient believed that they explained that it was a virus, but he thought it was like the flu or a cold. So he took his medications, and once he finished them and he was feeling better, um, he stopped taking them, right? He didn't understand his diagnosis. It wasn't explained to him in a way that he understood in the emergency room. And so he didn't realize that his condition was chronic and that he would need, care for a long time. And so we can see how in the continuum, how language may impact adherence and also can play a vital role in dismantling some of the stigma that is related to chronic health conditions, particularly HIV, right? So then I wanted to look at the figures for the continuum of care in Shelby County. And we'll sort of revisit this throughout the presentation, but I wanted to share, right? Like um, overall in the state of Tennessee, we see that 16.8% of late diagnoses are happening in the state, whereas Shelby County is doing better, right? The HIV testing is helping and it's only 11.2 in comparison. However, then we look at being linked into care and we see the figures um, sort of be under the state average, right? In linkage to care, in being engaged into care and in viral suppression. So first we're going to start our conversation about HIV prevention. And you all feel like a shy group, but please feel free to put them into the chat function. If you don't want to, like, raise your hand. I'm actually not sure how that works, but you can just unmute yourself and give me a shout. So that's not a. All right. So let's talk about HIV prevention. And so some of what the CDC recommends that dollars can be used on is, increasing access to and awareness of PrEP through innovations such as teleprep, expanding access to syringe service programs, right? And their capacity to provide integrated prevention services like PrEP. Oh, whoops. Can you all see? Hold on.
You're good.
Okay, great. I'm like, I can't see. All right, so am I on the right slide?
No,
I think I am.
Yeah, I think you need to back up a couple.
yeah, for
Yeah, right?
prevention.
I was like, I don't know what
There
happened.
you go.
There you go.
Okay. It's technology. So some of this means that what can we do as part of external programming, right? And that just means what does our community see from us? What do they receive from us? So that's how I labeled external programming. So that's how we're going to break it up, or internal practices and policies. And so when we think about, what some of the CDC funds provide or allow in this area, or what they recommend, or and you all have your EHE plan, right? But here are some places where we're suggesting to add some language justice practices as part of HIV prevention. So part of that means like having diverse PrEP and PEP campaigns, where there is a simultaneous rollout, which means that campaign materials and other information have to go out in Spanish and English at the same time. So it's not communities are catching up. And so this takes some coordination, right? Because sometimes we're like, oh, we're going to complete, and this happens to us all the time. And we're the Latino Commission on AIDS, where we'll say, oh, we're going to complete this by this time. But we still have to build in time to have everything translated, reviewed, and then published, right? And not all of our campaigns translate exactly the way they do in English. So sometimes in English, there's like really cute catch slogans for campaigns that don't necessarily make sense in Spanish, right? So there is some investment there. And like I said in the beginning, we do want to encourage folks that even if you all are not ready to, go completely bilingual and have everything in Spanish and English, and because it is an investment for us, I think our program budget, it is about 10% is around language services. And we don't provide direct services. So this is just translating and having interpretation available. Go ahead, Jesse.
Thank you. And also, with external programming, right? And this is kind of getting a little bit more into the niche. I also want to just reiterate and put some focus that it's also important to keep in mind that just like any other community, the Latino community is not a monolith. Oftentimes, people, when they try to market, they forget that people who speak Spanish come from various countries. And even though, yes, there are some similarities and overlaps, each group is a little bit different in terms of like culture, in terms of language. And so I oftentimes find myself people kind of just using kind of like one way of promoting things and assuming that it's going to reach the entire population. And so it's important to also understand and respect the rich diversity that exists within the Latino population. Thank you. Back to you, boss.
Thanks, Jesse. I think that's a great way to center that. And so some of the internal practices and policies is really like including um, navigators who or bilingual staff who are PrEP navigators, right? Encouraging planning for a simultaneous rollout and really integrating some of the services. So HIV prevention can also be integrated into other programming. But it also means that we also have to address some of this anti-LGBTQ legislation and anti-immigrant legislation, right? Some of the racist policies that exist and how our organizations can respond to them internally so that it reflects in some of our external programming, right? Okay, I keep doing that. All right, so let's talk about let me make sure I'm on the right side. Yeah, so let's talk about late diagnosis. So we saw here what the figures were for folks experiencing coming into emergency rooms or testing late, what that looks like. And so for Latino communities, I didn't have a racial breakdown of proportion for Shelby County, and I imagine it's because the figure is so low. It protects patients. That's what I think. It may just also not been available, but in Tennessee, the proportion of folks who are receiving a late diagnosis are 24.1% if you're Hispanic or Latinx. If you're white, it's 18.9. If you're Black, 13.5. So we can see here that there is a disproportionate figure at the state level. And so I wanted to ask y'all in the chat, or you can share out loud, why you all think that Latinx communities are receiving a late diagnosis, or from what your experiences are, what have you all seen?
Um, Hello, this is Dominic. For me, I think it has to do with access to, you know, language, or translation services. I know of a situation where a person, you know, even as something as simple as PEP, was basically just given the medication, no resources, no explanation of what was going on. But, the same thing with late diagnosis. They're told it's a virus. Here you go, here's the medication. And so the medication runs out and there are no resources whatsoever. And I understand that emergency rooms are busy places, but it's something you would expect to be explained to a person.
Mm-hmm. Thanks, Dominic. Any other folks have any additions to that as to why maybe Latinx communities are receiving a diagnosis late? Thank you, Ray. Language barriers. Mm-hmm.
I would definitely, yeah, I was gonna exactly compliment that language barriers. I think that that's the biggest issue is acknowledging, especially whether it's ERs like Dominic was mentioning, or even health clinics. Sometimes we don't necessarily in those settings have someone that can be in a relational type setting where they can, be on an individual's level and speaking the native language that is comfortable to that individual.
Mm-hmm. Yeah, thank you.
Another thing that I also wanted to share that Judith kind of touched on in some of the earlier slides is also looking at landscape, right? As we know, this isn't just unique to Tennessee, but in the South, right? There's a lot of rural communities as well, and unfortunately, there's a huge lack of not just Spanish speaking medical staff, but also clinics are closing down. People are having to travel long distances if they have access to transportation. And so it may be the fact that your clinic or hospital or ER might have address language barriers, but also thinking about communities that oftentimes aren't close to urban locations like Memphis.
Mm-hmm. Yeah, so we can also see that I mean, this could be an indicator that people are just not receiving preventative care too, right? And so folks are not having visits with their primary care physicians or getting tested regularly. Um, and that may be why when they're being tested in emergency rooms or through pregnancy or um, a variety of other places, it's not happening in environments where HIV advocates like yourselves are always at, right? And so um, it's important to take a step back and think about what HIV diagnosis looks like, but also what prevention looks like and what that language is about the importance of testing, right? And how do we reach those communities who may not be going to their providers? And it's explicitly saying, right, as part of our language, that HIV testing is free, that you don't need to have insurance, that we're not collecting, information that could impact you negatively. We're not sharing your information, right? These, some of this might be uh, information that, you know, other patients from other demographics already know, but it's important to sort of spell these out um, in provider settings and in your outreach settings so that folks understand, right?
And I'm so glad that you share that, Judith, because I also got to experience a lot of that firsthand when I used to do linkage to care and prep navigation, where a lot of people were afraid to access these resources, either because if they came out positive, of the fear of their status being shared to immigration, or vice versa. I would have individuals who wouldn't want to get access to care because they were afraid that, for example, I had at one point a client who was in the midst of trying to apply for a visa, and his fear was like, I don't want to come off as, I'm using the government for treatment or medication, which that was not at all the case. And so there is this notion of almost kind of fear around prevention and accessing these resources that for most parts in our community are aware that are free and most importantly confidential. And so I think that just kind of perpetuates some of the fear and stigma that kind of lingers within the Latinx community.
Right. And so when we think about when folks are receiving a diagnosis, right, and that process of folks coming to you all and being tested, um, what are some ways for external programming that you all see or that you all implement? Some of the recommendations we have is making sure your testing forms use affirming language, that it's accessible in the language that your clients or your patients need, right? Um, Making sure that language being used in both in conversation and on paper or in documents are simple and easy to understand. So people understand their diagnosis, they understand the instructions. Um, you know, in the marketing that we share, I shared some pointers around how we convey to communities that coming to us, it's safe. We're not sharing things. We're not um, trying to, that their information is confidential. Um, so all of these things are important externally. And if you all can think of more, please put them in the chat, right? On what approaches, and maybe you all have your own approaches on what you all are doing in your communities, and I'd love to hear or read that in the chat too. So feel free to interject. When we shift into some of the internal policies, we can think about do we have bilingual staff, right? Are the folks testing, the folks doing the prep navigation bilingual, or are we maybe hiring interpreters to be on site with us to help with that piece so that there's more accessibility to the client or patient or community partner? And then um, are we showing some empathy and cultural competence or humility, responsiveness as we're sharing diagnosis information? because really the lack of language justice really negatively impacts the likelihood that non-English speaking community members or clients succeed in being able to navigate that HIV care continuum, right? And achieve and maintain a viral suppression. So it all starts here at HIV navigation or HIV diagnosis, right?
hmm And then with cultural responsiveness, I'm glad that Judith kind of put that in the slides because we recently developed a training that it's a HIV 101 for language workers. Because again, cultural responsiveness is a huge factor in this, right? You can hire someone who is a certified interpreter or translator, right? But just because they are certified in that one area doesn't necessarily mean that they are subject matter experts around HIV. And as we know, even with accurate medical translation, some of these terms can still have some stigma to them. And so, making sure that the persons that you're bringing onto your teams are also aware of again using these affirming languages, using non-stigmatizing language when working with clients, and specifically when discussing things around HIV, whether it's prevention or once diagnosis, because that can also deteriorate whether someone feels comfortable, whether or not someone stays in care. And so, it's going that extra step, right, of not just making sure that you have bilingual staff, but making sure that that staff is also culturally responsive to the community that they're trying to serve. Thank you. Back to you, Judith.
Thanks. And Elizabeth put in the chat, well, we have the technology and technology accessible to have interpreters on the phone. I'm thinking that this could make someone uncomfortable because it's not necessarily someone on site. And I think the some of what Jesse shared right now really speaks to that, in that um, if you don't speak the language, you don't know how well things are being interpreted, right? And so you get into an area where yes, you're doing your best to convey a message, and that may be the first step, right? Is like, let me just get the message across. But I think there could be some scripts available, or some documented information where you already know, what is um, where you answer some frequently asked questions, right? With language that you know is not going to be stigmatizing. Because sometimes these translation services online will do, like, they'll put it in ways that aren't always sensitive, and so we have to be mindful of that. And then aside from that, we also have to think about what happens um, when you have an interpreter who may feel uncomfortable talking about HIV. So these are all things that do require some training, and making sure that the language that they're using in Spanish is also not stigmatizing, that they're aware of people first language, right? That we're addressing and reaching out to people in the best way possible, right? So let's look at now link to care. So I just want to say that in Tennessee, y'all are linking the Latinx community to care. So we can see here that in the state of Tennessee, it's 83.9% that Hispanic and Latinx communities are being linked to care in comparison to Black and white communities. And in Shelby County, it's 75%. So Latina communities are getting linked into care at higher rates and visit their provider at least once, right? Once they have their diagnosis, at much higher rates than other communities within that month, right? So that is something to think about, is like, once Latinx communities receive a diagnosis, Tennessee is doing a really good job of trying to link them into care, and communities are going, right? So what are some strategies to maybe like continue to improve that for this next piece? And in terms of some, like, linkage to care is the most successful when folks are immediately referred into care. And I know that that was something that changed in the HIV space, you know, fairly recently, I guess, where folks no longer had to wait to start antiretrovirals, right? We're doing a better job of trying to get folks on their medications that they need without having to wait. But establishing a relationship with someone immediately that speaks their own language really increases the success of patients in attending their first appointment and ongoing appointments, right? And so it's important to have consistent policies that create systems of trust. And often, you know, providers, social workers that are trained on gender affirming care, that's who's being trained, right? Like we see social workers, providers, nurses, um, receptionists, but what about your finance and billing folks, right? How are they doing the billing? How are they being culturally responsive? How are folks receiving mail and what name? You know, are we dead naming folks unnecessarily on envelopes, in other places that can be triggering? Or how do we ask that, right? Are we asking that in the forms? So those are all things that you can do in terms of some of your external policies. Internally, you know, people may not be able to access insurance information because of language barriers, right? What are some of the policies that you have that can be affirming to Latinx communities, to LGBTQ communities, in order to provide the best services? So investing internally and externally to incorporate some of this language justice practices throughout the institution organization policy, like looking at your policies, your budget, your values, your mission, the investments you're making, and how we're incorporating language justice there, right? So we want to make sure that there are consistent policies so that folks who are moving through the system understand what it means, what that means for their providers.
I also wanted to add that, aside of gender affirming care and gender affirming language, right? Going back to the notion of being intersectional with the work, right? You guys can definitely implement a lot of what we do already with the English speaking population and mirror that for the Spanish speaking population, right? So not only making sure that it's gender affirming and inclusive, to keep in mind of the LGBT community, but also making sure that the language is simple. You know, we all talk huge about this when serving the English speaking population, right? Making sure that the information is given in a way where it's not overwhelming and it's simple and direct. And then I also wanted to kind of briefly just highlight that, I think one of the successes on why we're doing so well as a state, but also as a county in linkage to care, aside from the waiting period being shrunken, right, and being much more easier to get people in, it's also thinking about who is doing the linkage to work. Oftentimes it's PrEP navigators, oftentimes it's HIV testers, right? It's a lot of people that are doing a lot of community engagement. As I like to say, it's people that are in the trenches. And so I think that's also where you have those strong referrals, because it's oftentimes people from those communities that are part of those communities that are essentially out here doing the work. And so it's just, I wanted to reiterate the importance of when hiring and bringing people on your team to making sure that it's reflective of the population that you're serving, because that's a huge helping factor in linking folks into care. Thank you.
Thanks, Jessie. Did it click? Okay. Okay. So being retained into care, right? Or receiving care. And so in Tennessee, in the state, we start to see a decline in Latinx communities being retained into care. So we can see here that Black communities at 77.8% and white communities 81, right, at the state level. And then in Shelby County, it's a little bit lower, right? Except for with white communities, where we see a bigger, more substantial drop than with Black and Latinx communities. But we can see that that's a very big difference from where we started and let me see if I can go back. Am I going back? Yeah. We're here where we had 75 and 83.9%. So we can see that of those being retained into care, we are seeing a drop in folks staying with their providers, at least for that first year. And so while Latinx communities are getting linked into care at higher rates and visiting their providers once a diagnosis, we aren't seeing, folks being retained into care at the same, rate. It's not as high. And why do we think that is? Why do we think that in retention or receipt of care, we see this drop?
I guess I'm complimenting kind of like the mention of, having those interpreters accessible by phone or things of that nature, or even virtual platforms. But more or less, like I'm thinking it's the comfort. Like it may, like, in Memphis, or honestly, a lot of times when you talk to medical entities, we're talking about and adapting to treating the whole person, right? So treating their mind, body, and spirit. And so I'm just curious, and I wonder if that's very well the case in this scenario as well.
Mm-hmm. Absolutely. So language does play a huge barrier in folks continuing care and understanding that they need to continue care, right? Um, Anything else folks want to add?
Yeah, I just wanted to quickly just mention, very much going back to the theme of intersectionality, right? When we talk about the retainment and care, specifically speaking for the LGBT community, right? We see that oftentimes a huge reason on why we have such a low number is because there is a lack of respect, visibility, like Elizabeth was saying, treating the person as a whole and not just as a number. And so, these things that oftentimes people might find trivial or not as important or a priority, are actually huge determining factors on whether someone comes back to your office or comes back to your clinic. And so again, just making sure that we're also looking at this through a intersectional lens, right? And making sure that when these conditions are not met or thought about, it really does affect the client's experience. And honestly, it uh, it discourages them from wanting to come back.
Thanks, Jesse. Whoops. And so when we think about being engaged or having retention to care, this is the piece where in the first couple of visits, we really need to establish some trust, get good contact information. Lord, we we have some issues too on our, like, we provide scholarships for a conference, and sometimes we are contacting folks through smoke signals to try and get carrier pigeons. So it is understanding those pieces, but aside from that, it's also being able to develop trust really quickly and having consistency and having knowledgeable and affirming providers, right? Having a good experience from the front desk to billing, right? The whole process, so that folks um, feel like going to their provider and they understand that it's important to continue to receiving care. And so being able to have some of that patient navigation, sometimes it's really difficult for medical providers to share things with their patients and vice versa. And so in turn, it makes it really hard for patients to self-advocate, right? Because there isn't a way to do that. And that's a big piece. Being able to self-advocate for your needs and concerns and feel like folks are heard, right? We often see providers seeing patients for an average of 12 minutes, right? And so when you add an interpreter there that is, having to go back and forth, that visit could be reduced, right? Because the provider doesn't have as much time to have those conversations. So these are all things to be mindful. So being able to some things that I think around patient navigation also includes like being able to schedule, cancel, reschedule appointments without some of these barriers around language and even technology, right? Some folks are just not familiar with our online systems, and that may be the only way option that is quicker for folks to get attention. When COVID-19 happened, um, I was trying to make appointments for my parents to get vaccinated, and it was really hard to use their online systems. And I know that had my parents tried to do it, they probably would have given up, right? They would have had to have waited a couple of months before they would be able to access appointments. So these are all things that we need to understand, that certain communities are just don't have the accessibility, especially in rural areas where maybe internet is unreliable. And as we move towards things like teleprep or telemedicine, it's making sure that patients understand how to navigate the technology ahead of time, right? It can be uh, really intimidating, I think. Um, we also need to do some internal policies in terms of how we have flexible care models, right, to support the needs of community. And that could mean extended hours, because we know a lot of Latinx communities are not going to their doctor's appointments because they can't miss work, right? And so, and that's true for a lot of other communities too, right? I think that a lot of folks who are working in service industries, right, have less flexibility than say if you work a corporate job. And so we can think about that and think about who our clients and patients are, to make some of those changes and add some flexibility. Um, if when we have written or mailed information, uh, here in North Carolina, we expanded Medicaid, and they sent out notices to people on a different medical plan, letting them know that they were eligible. What they didn't anticipate is that people do not read their mail. They were not picking up their mail. They didn't look at it. And so then the North Carolina Department of Health had to go back and get more creative and invest in other ways to communicate to folks that they were now eligible for Medicaid, which is really important, right? And so it's, thinking about these things prior to, right? Prior to the rollout. And then being able to incorporate what data to care looks like. And that means like we want to make sure that we are looking in your jurisdiction, like who tends to fall out of care in this jurisdiction, right? And so we saw the figures. And so how can we measure why people are falling out of care, right? And why people are not being engaged and retained in care? Why don't they come back? And it's being able to do that assessment, interviewing patients who may have not come back to care, and maybe we find like they're moving away, things are happening in their lives, but also we may find other reasons that could lead to some improvements and to some internal changes, right, in how we operate. And right. So being able to adapt to today's world, like what are people using? How are we communicating with folks is important. Mhm. Let's see. Oops. Okay, now let's look at viral suppression, because I would do want to get to a piece around where we do our own assessment of ourselves. Oops. Okay, so in Tennessee, we see Latinx communities being virally suppressed at 61.6%. And in Shelby County, sorry, y'all. trying to close some of this stuff. Okay. And in Shelby County, we see 57.1%. So we also see a decline in how many folks, and this makes sense, right? If we don't have people who are engaged in care, we're also going to see folks maybe not becoming virally suppressed. And there are other, right, factors, right? People may be uninsured and don't understand that they can receive some of their medications at no cost. They may not understand the Ryan White program, right? So it's like a few of these things. But we can see here that these are at in Shelby County, it's lower than the state proportion overall, right? With Black and white communities, including the Latinx community. So we can think about what some of the external programming can look like around language justice here. And some of it means like providing some emotional and physical support from providers, case managers, or whoever is part of the care system to provide those services in a language that the client and community understands, right? Continued patient navigation, right? And being able to talk to folks about what are some of the barriers that are preventing them from obtaining viral suppression. And then finally, in some internal policies and practices, developing some formal and informal partnerships in order to ensure that we are connecting our communities to the services that they need, right? We want to make sure that if a patient needs housing, they're connected to, an organization that can provide housing. Because if they're unhoused, right, it's hard for someone to focus on their health and making sure that they're staying well and on top of their medications. If they're having other barriers in their lives, it impacts it. And so understanding in that relationship what that looks like and being able to create partnerships, formalizing some of those partnerships, right? Signing MOUs with other organizations, partnering with communities to ensure that, like, if I refer someone, and sometimes you have to do a little bit of secret shopping, right? We do secret shopping all the time, where we contact a provider to see what it's like to get PrEP there, or it's part of our assessment, right? Like talking to different people without them knowing that we're doing the assessment, so we can get some honest and provide some honest feedback for providers about how they can improve their phone rapport, or the knowledge that maybe some of the folks have in order to sustain better relationships with patients, right? And so I did want to share how we have supported language justice practices sort of externally. And that includes, like, we've conducted organizational assessments in the Southeast and trained language justice advocates. This figure is actually incorrect because it doesn't include the training that Jesse has done with language workers, so that there are more interpreters available in the South for community events, right? We have advocated for additional funding because we know that this is a investment, right? And as we go through this, I just want to remind folks that the investment that we're asking folks to make or encouraging people to make around language justice doesn't necessarily just mean that someone immediately has to hire a bilingual staff member, because we also understand that, if you're only seeing, one or two individuals who are monolingual Spanish speakers, like maybe developing a different system. But you can start to put signage up in your offices, or you can start by changing your intake forms and having them in Spanish and English available, so that folks who are helping them can help navigate folks through those services. So there are strategies we can implement. And so we've worked alongside VIV and Compass, the Compass Initiative. They have the University of Houston that has some funds to promote language justice. There is Colibri Academy, which is through VIV and Tilde are some language partners that we use. regularly. And so they have assessments also for organizations to go through, and it's free to the organization, right? But the Compass Initiative has funding available if you want to explore language justice at your organization with some guided training. So I did want to offer, well, we always want to offer something, right? As we're hoping people move through this phase. And in the change model, I was talking to Jesse about it earlier. I was like, you can jump in at any part. If you're in pre-contemplation, contemplation, you can jump in any part, but we want to make sure that people are thinking about this. And so I did want to go back to our Mentimeter. So if you have it pulled up, I'm going to ask you all a few more questions, and it's really like a survey. And okay, so we're going to start by asking some questions, and know that these responses are going to be anonymous, so don't worry. So the first question is, does your organization have multilingual staff with clearly defined roles and responsibilities? And if you need any clarification, please let me know. And Jesse dropped the link in the chat in case you needed it. Okay, so we have a few folks voting. Great. And it looks like we have about 11 participants, but I think that may be including. Great, so we're seeing some folks who are unsure. I'll give folks like one more minute to vote.
In the meantime, we do have a question in the chat box. Judith, it says, do you know of any places that offer free or inexpensive Spanish language lessons for nonprofit orgs?
Yeah, so we've seen, for example, Alabama, the University of Alabama started providing medical interpretation and Spanish language classes to providers and nonprofits. So I'll try to find that. But there's also at the state level, they should be creating language access plans. And so they should have some more resources. So I can have Jesse share that with y'all's group, or Elizabeth, right? We can compile some resources for y'all. All right, great. So
Absolutely. I would, and sorry, Judith, I would just say, as well as like, if you want to include in material when we do share the recording to the technical assistance training, I can make sure to hold off with Sherry, and we'll wait for additional materials to be sent by you all, and we'll include that.
yeah, that sounds good. Okay, so it looks like some of y'all are doing this all the time, right? You do have staff who speaks different languages, and they have very clearly defined roles and responsibilities. So that's excellent. That's a very great first start. We had a few folks who were unsure of whether that was happening, and that's okay. It depends, not everyone has access to all that information. All right, here's our second question. Does your organization ensure that people living with HIV and impacted communities have a variety of roles at different levels of the organization? So oftentimes we see, well, actually, I don't want to skew the results. All right, we have one person who's in progress. They've started. All right, it looks like we have folks who have started this. one person who's not really doing it and not thinking about it, and then we have someone who's unsure. And so what this really what this asks is, like, when we talk about people living with HIV and folks impacted, often we hire people who are living with HIV or impacted by HIV, and the search is generally for like outreach workers, right? And line staff, right? People who are out in communities. But there also has to be outward mobility and economic mobility for people who are living with HIV and impacted. And at the same time, having people who are impacted and living with HIV at different roles helps us ensure that we are fulfilling MIPA, right? Meaningful involvement of people living with HIV, and getting information from communities who are being impacted about how some of our policies and practices and future investments look like for their community, right? So it's about having more stakeholders throughout the organization who are invested in ensuring that and are committed in a different way, right? Because it's through their lived experience. So this is great that we have folks who are starting this and who are working on this, right? See our next question. Does your organization specifically budget for language services? And this can include interpretation, translation. It can include some of these trainings that folks are doing. We've talked about other ways, but that you know that your organization budgets for this specifically. Okay, some folks are unsure. Some folks are doing this all the time, and others are in progress. That's great. And so these are questions also that we can be going back to our colleagues about whether we're budgeting for these services and what we need to do to begin to budget for some of this. And budgeting also means that we're hiring bilingual workers, right? That, like, that's part of the budgeting that we do, and that we're paying folks for this added skill that they're bringing to the organization. All right, great. Well, I appreciate you all and your candidness in sort of sharing what this looked like for y'all. All right, let me. Oh, I think I had one more question. Okay, so does your organization encourage and advocate for non-English speakers to participate in ending the epidemic local and statewide plans? Great. So it looks like some of y'all's organizations are doing this all the time, right? Encouraging folks and advocating. And that advocacy could look like ensuring that interpreters are at the Ending the Epidemic planning meetings and statewide meetings, and making sure that folks can participate, making sure that the hours are work for community members, right? Having that coordination, surveying the folks and stakeholders who are attending some of these plannings. So that's great. And I'd love to see that people are thinking about it. Hopefully some of this training will, or workshop will help y'all like move that advocacy to in progress, right? Okay. Let me move back to so here's some just general recommendations that I wanted to provide as we begin to close out. And please feel free to put any questions in the chat. But honestly, you know, once you all, some of these language justice practices can mean different things in different ways, as I've mentioned, right? And so if you can't do anything else, right? Beginning by investing in some interpretation at events, meetings, and service settings, right? And here's how we do it. We generally have an interpreter, and they make an announcement saying that interpretation is available in both languages. Sometimes we encourage folks to flip the script, which means that the meeting will be led in Spanish, and then everyone who is not a Spanish speaker uses the equipment, right? So that they also get a sense. We have people welcome people in their own languages, right? And we offer equipment to everyone. If you've attended one of our conferences or meetings, we offer equipment to everyone because we want people. It's not just about translating the speaker into English, but also what if an audience member has a question and it's in Spanish? That way, the speaker has a direct line of interpretation so that they can understand and reply, right? And so it's a more natural conversation than going through a third party in that way, right? Translation, right? Like thinking about translating all of your documents. And we can see here the difference between interpretation and translation. So translation is written or read, right? So we have translation. So making a plan to translate documents, websites, social media channels, right? We developed a style guide, which means that the way we say things may not be the way St. Jude says things, right? The way we say things in Spanish may not look like how you all want to say things in Spanish. So our interpreters know, we give them like a little glossary of how we say things, right? Like this is our name in Spanish, La Comisión Latina sobre el SIDA, right? But people sometimes are like, they're mixing up our acronyms. So we're like, this is how you say our name in Spanish. And that just leads to consistency and appropriateness, right? Like it reflects your organization and who you are. And then again, making sure you have a simultaneous launch, making sure if you're publishing materials, it's not, we're going to publish the English version right now. And we saw this a lot with COVID. We saw a lot of campaigns come out in English, and then maybe like a week and a half later, the website was available in Spanish. And that delay creates confusion. It signals that certain communities are not as important. So like this investment is really important in terms of healthcare. We also want to encourage y'all to invest in people, right? And I think making sure we're hiring trained language workers and contractors. And that means people who can talk about HIV from a place of knowledge, in some cases, people who are impacted from a place of experience, right? So we want to make sure we're hiring trained language workers. That doesn't mean they have to be certified, right? Like we also need to value that. And this is for more so not in clinical settings. I want to be clear there. Please follow your state laws regarding or your hospital rules regarding that. But for community settings, right? We also want folks to be recruiting multilingual staffing and volunteers. Volunteer opportunities should also be available to folks in Spanish. We want people to be invested in their communities, and volunteering is a great way. Staffing is a great way to bring new networks. You know, if we have our annual conference, and last year or the year before that, we did it in Durham. It was Jesse's like first year working with us. And we had so many more folks from Tennessee attend. We had so many more folks from Tennessee attend. And so bringing on staff opens up networks that we couldn't have if we weren't there, right? And so that's part of the importance here. Inviting English language learners onto, and I'm using this specifically, right? There's people who are monolingual Spanish speakers, but you also have people who are learning English. And so they can participate on advisory boards, advisory groups, and staff too, right? And we need to have a continuous improvement approach. And that's part of that data to care piece that we talk about in HIV spaces. However, you should be auditing your own language access practices, what you all do, what communities, like, do they like your interpreters? Right? Like maybe they don't like your interpreters. And I mean, it's possible. Maybe they don't understand the interpreters, but no one's ever asked them, right? No one's been asked, how do you feel? Evaluate the interpretation today. when we have staff meetings and we have interpretation at our staff meetings, there's a little survey that we should be sharing with staff about what did interpretation look like today? Are you satisfied? Those should be part of the evaluations. And really making a plan and funding it, right? And like I said, this doesn't have to be something, I don't want this to be intimidating for folks and doing it all at once. I mean, if you can, but you want to be able to create a plan for sustainability, right? To make sure that we are moving in community in ways that they agree. All right. So then I have some resources here. I wanted to share Tilde, who we use around some interpretation and translation services. They do our virtual interpretation and translation, but I'm going to share this in the slides where you can visit their website. And they also do that Colibri Institute where they do the assessment. For people first language, if you need some more guidance around that, they have really great charts about people first language. And then communications, additionally with the Positive Women's Network, they have some great resources as well as embodying meaningful involvement with people living with HIV. So at this point, we're right at 2 minutes. I'm happy to answer any questions if anyone has any. But I also wanted to share our contact information in case y'all want to visit me in Durham, North Carolina. We're hosting our annual Encuentro conference, which is an LGBTQ Latinx conference around health and HIV in Charlotte this year. So we're just going to be around the corner from y'all. I hope to see a lot of great folks from Tennessee there. But yeah.
I also wanted to just add that if you guys are interested in getting more information on the conference, I saw you, Ray Rico. I would be more than happy to share that with Elizabeth so she can have that for the next C2P meeting if any of you guys attend. But also feel free to reach out either to me or Judith specifically. There'll be an opportunity for scholarships as well as presenters. I always brag on Memphis. We have a lot of people that have been doing incredible work for such a long time. And I feel like this is also an incredible platform for not only for us to go and learn, but also to share, highlight, and celebrate some of the incredible work that we've been doing here in the 901. So yeah, for more information, I'll make sure to put my email in the chat if you guys want more information specifically about the conference. But yes, thank y'all so much for engaging with us. And thank you so much, Judith, for taking the lead on this incredible presentation.
Did anybody have any last minute questions that they wanted to drop to us before we close out? I know we are currently at the half hour, but this was a lot of robust information, and we do have readily access to our wonderful friends with Latino Commission on AIDS, especially our native Jesse. So any last minute questions that you all want to share, gratitude, information? Viva Memphis.
Yeah,
Love it.
and just to kind of echo what Elizabeth said, you guys, as y'all know, even though I'm with the commission, I'm still based locally here in Memphis. So if anyone would like to schedule either a virtual or an in-person once the snow officially melts, I'll be more than happy to meet with you guys and again like talk about this in more specific to either your work or your organization. Again, like Judith was saying, this truly is an investment, you guys, and we want the whole goal is for you guys to again see this as an opportunity rather than a burden or an afterthought. And again, just a reminder that if our work is not intersectional, then we truly are missing out. But yeah, other than that, again, I'm always here for you guys to discuss things in further detail. And just thank you, Elizabeth, and thank you, St. Jude, for the opportunity.
Absolutely. Thank you so much. With that being said, we appreciate everybody who'd been on. We can go ahead and stop the recording. Sherry, I don't know if you have to do that on your end.